Hate definitions. Oh, y'all know all those. Alright, so hypomobility could have an intrinsic cause or an extrinsic cause. Extrinsic, pretty obvious, you know, if you cast somebody, you put them in a splint, what have you, that's gonna make things stiff. But intrinsically, pain, how does that make something stiff? They're not gonna move it. Correct. How could a fusion make something stiff? Has anybody had a joint with a fusion? Young, healthy people. Very hard to move a joint. It's an effort. It doesn't feel good, and it takes more effort than you could ever imagine.
It's like there's more in there.
Yeah, it's sloshing around and just feels miserable. Weakness, obviously, if they're weak, it's going to be harder for them to move a joint. Tonal abnormalities, here comes the neuro reference. I just get to just defer those all semester. Habit, oh, that's kind of interesting. Anybody got anything for that?
Posture?
Yep. That wasn't what I was thinking, but that's a good one.
Someone might walk with like a limp for a really long
That's
time.
what I was thinking.
It's hard for them.
They kind of get it ingrained, that gait pattern gets ingrained.
They get used to substitution.
Yep. Yep. Skin disorders. If you have somebody who has a burn or something like that, that will provide a contracture very, very quickly, and it's one that's really hard to deal with. Muscle disorders, you know, there's all kinds of pathologies out there that are going to affect range of motion and so forth. You're going to see all of those. You're going to have to deal with those. How are we going to deal with those? So, contractures obviously are going to lead to impairment. Designation of contracture by location identified by the action of the shortened muscle. So if you hear someone has an elbow flexion contracture, what's that going to look like? Like this. It can't extend. Okay. Hip adductor contraction. That's going to be somebody with this scissoring. They can't move their leg out. Okay, or move their hip out. Contracture versus contraction, not the same. Not the same at all. Contracture implies an involuntary set of circumstances. So, myostatic is a muscular tendinous shortening, resolves with stretching. Pseudomyostatic, this is going to be caused by some type of neurolesion, from guarding, spasm, all that type of thing. Inhibition, again, you guys are going to talk about, will help with the elongation of that. If it's arthrogenic, if you've got somebody who has a torn meniscus in their knee, that could be an arthrogenic pathology. So when I hurt my knee, I could not fully extend my knee because of the pain and the joint effusion and all that good stuff. Fibrotic changes, again, I think of scarring, I think of, again, burns really tend to, anybody seen somebody with a burn that leads to a contracture? That is really tough to deal with. Really tough to deal with.
There's a guy in Opelika, I can't remember his name, but he has burn all over.
Yeah.
And his, his hand, his arm, his neck even.
Yeah, I mean, it gets
Got a lot of scarring.
Selective stretching. This is an interesting process. And again, you guys will touch on this in neuro. Which overall function may be improved by applying stretching techniques selectively to some muscles and joints, but allowing limitation of motion to develop in other muscles and joints. So, the best example I can give on something like this, if you've got somebody with a spinal cord injury, okay, and you gotta remember they're flaccid from wherever the lesion occurs down. you want some rigidity in order to help you with transfers, with the propping up in a bed, even seated in a chair, wheelchair, what have you. So Jordan will talk more about this, but this is a very, very real thing, okay? You will let them get tight in certain areas. I have to think about it. I think they want, for the most part, you stretch the hamstrings, but you let the back extensors get tight, because that keeps them in an upright posture. Does that make sense? Because if these get stretched out, they're just kind of floppy, because there's no tone to them at all, okay? But you gotta keep the hamstrings limber, because you've gotta be able to move and get them in and out of bed and into a chair. Transfers are really something to think about. Overstretching and hypermobility, we got plenty of that in here. Stretching beyond the normal length of the muscle, resulting in excessive mobility. Yes, athletes, some of us are athletic. But yeah, we've got to watch out, especially in shoulders. We've got lots of loose shoulders in here. You don't want to overstretch people either, depending on what they're doing. Interventions to increase mobility. We talked about passive stretching, active assistive, self-stretching. These are pretty easy to define and so forth. Specific interventions, neuromuscular facilitation and inhibition techniques. All right, we're going to touch on a little bit of these. But again, a lot of these will be covered in neuro as well. So the neuromuscular facilitation techniques, you're trying to relax tone, if you will. We weren't allowed to use the word tone in school. Our teacher would flip out if we used it. It was resistance to passive movement. Does everybody see the difference there? There is no difference, but so if you felt somebody with rigidity and you try to move it, it's almost like a cogwheel thing. That's resisted to passive movement or tone. Yeah.
Is it kind of like when you're trying to get them to sit down? They're really stiff and they're kind of like fight you, trying
It's
to sit?
usually not the sitting, it's more when you're trying to stretch a limb. If you've got somebody with this kind of flexor synergy or whatever, you try to stretch them out, it just gets very cogwheelish almost. So you'll use inhibitory techniques to reduce that. Muscle energy techniques are osteopathic in origin. We will work on some of those as well. Those can use some contract relax techniques and so forth. Joint mobilization, manipulation, we'll talk about it at length and practice quite a bit. Soft tissue mobilization, you guys have already done a good bit of that. Neural tissue mobilization, again, we've talked a little bit about that. Neural glides and so forth. Remember our guy with the little video moving yeah, that's what we're talking about there. So again, you have to think about how specific you want to be with these things. Indications for stretching. This is me right here. Someone with adhesions, contractures, and scar tissue, we need to stretch certainly. Muscle weakness and shortening, absolutely. If it's part of a fitness program, if we've got people on wellness programs, whatever, both before and after vigorous exercise. Studies have shown that that's going to be helpful, both ends there. Contraindications, again, boards love this. When do we not stretch somebody? We have a bony block. Bony block is going to be very rigid, a very hard infield, maybe painful. Non-union fracture. I told you about my guitar player, right? Told you that story? I can't believe I've told these stories too. So I had a guy, complete idiot. He was a guitar player. He played in all these honky-tonk bars and stuff. And somebody was getting ready to hit him with a pipe. And he stuck his arm up. Hit him right here. Shattered both radius and ulna. So, I mean, it's like massive, ugly, ugly break. Put him in a cast, And the cast comes up above here because we don't want them to supinate and pronate as well, right? So the cast is up here. Well, he's a guitar player. He can't play the guitar. That's what he does for a living. So what does he do? He cuts the cast off and he starts playing guitar. Yeah. So what happens? Non-union fracture. He's now got a second elbow. Never closed. Never closed. So he's got an elbow here and an elbow here. It is. It's just, I mean, you watch him play guitar, it's just, oh yeah, yeah. Not the most functional arm you've ever seen. And a doctor sitting to me. What am I supposed to do with this guy? Oh my goodness. He was something, let me tell you. There's no way that guy's still alive. No way. Absolutely no way. All right, so we won't stretch fractures that aren't healed. We're not going to stretch active inflammation or infection. Why?
What?
Could it spread the infection? Probably could. Could it help facilitate more inflammation?
Yeah,
Absolutely.
that's what it causes.
Absolutely. Sharp or acute pain with elongation, that's just kind of common sense. Hematoma or tissue trauma. Now, see, I don't know about, I would say that's a contraindication. I think that we put that on the continuum. If it's very acute, if you've got somebody with a humongous bruise that just happened, yeah, we're not gonna stretch that. But if it happened a week ago, probably gonna stretch some of that. Hypermobility, don't wanna stretch people that don't need to be stretched. And hypermobility, this is the spinal cord patient that we were talking about. The hypermobility provides stability, okay? That's a very real thing. You gotta keep that for function. Potential benefits, obviously increased range, general fitness, prevention, maybe. Not been a whole lot proved there. Reduced post-exercise soreness. There's been some studies that have shown that. Enhanced performance. Yep. Yep. Regular stretching may be more beneficial than acute stretching. Would highly agree with that. Let's talk about that enhanced performance for a second. Sprinters. You have any sprinters? Y'all too smart for that. Sprinters. Do you see them stretch a bunch before their race? Oh, yes, it's dynamic. It's not static stretching. Because static stretching will slow things down. Okay. So these elite athletes that you see doing sprints, jumps, things like that, almost always going to be dynamic warm up, not a static stretch.
Okay, they tell you to do static stretching like post-exercise.
Yes.
To help, like, does that help with like the recovery of your muscle?
Maybe a
tone?
little bit, yeah. That's a lot of mixed evidence there. Some people say no, it does not at all. Some say, well, we got some studies that say that.
Is there
I don't think it hurts.
is there a benefit over static over dynamic anytime?
Yeah, we'll talk about that. We'll talk about that in just a few minutes. All right, so we got to talk a little bit about some physics here. Oof, painful, I know. That's the one prerequisite that I wish you guys made you on tape, but you don't have to. Physics would help. Would help.
No.
Elasticity, ability of soft tissue to return to its pre-stretch resting length. Okay, if something is elastic, you stretch it and it comes back. Right? If something is viscoelastic, it forces sustained. It allows for change in length, but the tissue return to previous lengths after the force is removed. Okay? Plastic. If something is plastic, it is deformable. Put stress to soft tissue and it assumes a new and greater length, even after the force is removed. So which one of these are we? We are all of these things. We are all of these things. Connective tissue, all the things you learned about in A&P, is the primary sources of muscles' resistance to stretch within those muscle cells. Initially, the connective tissue resists strongly to stretch, but then it will have a give to it. I'm not going to go into all this muscle physiology. That's a whole new course if you want to go get a master's degree. But prolonged stretching can lead to more permanent changes with this viscoelasticity and plasticity. But if you allow them to rest in a shortened position, in an immobilization case, adaptive changes that are negative will occur. Immobilization is really harmful. You know, you always heard about people saying, oh, I'm gonna put them on bed rest. Probably the worst thing that was ever, other than the, you seen the old ads like from the 50s and stuff that smoking was like glamorized and, you know, maybe even thought to help you relax and all that kind of thing. This might be the only thing that was second to that. So putting people on bed rest, what does it do? Well, atrophy occurs very, very quickly, and more rapidly in the slow twitch versus the fast twitch fibers. Motor unit size decreases, okay? Mobilization in a lengthened position may increase the number of sarcomeres in the series to promote optimum overlap of actin and myosin cross filaments, all this stuff, don't worry about that. 3 to 5 weeks of normal use, that's what it takes to overcome a small period of immobilization. So you lose it much quicker than you gain it. Okay? So it's very, very rare. Matter of fact, I can't really even think of anything now where they will say, go home and do nothing. I mean, total hip replacements are up an hour after their surgery. Knee replacements, very similar. Shoulder surgeries, intricate shoulders, even total shoulders now, get them moving quickly. Oh goodness, muscle spindle, Golgi tendon organs. All right, so you've got to just know what these are to get to the next step. Muscle spindle is a sensory organ of the muscle sensitive to both stretch and tonic stretch. Golgi tendon is near the musculotendinous junction, monitors tension. So, we're not going to get into all these gammas and all that kind of thing. I want you to look at this stretch reflex here. So, we've got somebody. We hit them with a reflex hammer. Bang, stimulus. We tap the tendon, which stretches the muscle. Can we see how that stretches it even momentarily? So our muscle spindle stretches and fires. Sends an afferent pathway message to this sensory neuron that's located in the spinal cord, okay? This integrating center here in the spinal cord. It doesn't even have to go to the brain. This is a reflex. This happens right here, comes out of efferent path, comes to the quadriceps muscle, boom, it kicks out. Happens that quickly. You've seen that a million times, right? This is the pathway. Right? This does not incorporate the brain at this point. You certainly feel it, right? But you don't have to think about it for it to happen. This happens automatically if this loop is intact. It's the same thing we just talked about right there. So, when the tension develops in the muscle, that Golgi tension organ fires, decreasing the tension in the muscle being stretched. Okay? So if we go back, we've got the quadriceps contracting, but the hamstrings will be inhibited. Okay? We need to have that relationship for this to occur. Because if the hamstring's not relaxed, that's not going to happen. Okay? That's reflex inhibition. That's what happens to the hamstring. What we see is what happens to the quadriceps. Reciprocal inhibition. Stimulation of one set of motor neurons is accompanied by inhibition of neurons that control the antagonistic muscle. Okay. So how do we stretch? Prolonged stretching allows for accommodation and is much preferred over the quick, short duration stretching. This autogenic inhibition effect contributes to that reflexive action. You've got to have the ability for one to move by the relaxation of the other. Take home message right here. To achieve change in muscle length, a long sustained stretch is preferred over a short fast stretch, because a short fast stretch will not allow that reciprocal inhibition to fully take place. Are we good on that? Take home message. You can take out all those tendons and all that stuff. Long sustained stretch is the key. Lots of types of connective tissues. I think you all would agree with ligaments, tendons, joint, fascia. Look at this, skin is connective tissue. Some texts list it as an organ. And you may see that. So this non-contractile soft tissue made up of collagen, elastin, reticulin, and ground substance. This is the stress-strain curve. It's pretty universally accepted here. As stress increases, we see more strain. So when we say elastic range, what does that mean? So elastic means that if we take this amount of stress at the elastic limit, if we stay below that, of that amount of stretch, our tissue will go back to the same length that it was before. Okay? If we go past that elastic limit and increase stress even more, we're then into the plastic range. This is where we are lengthening tissue. Okay? If we get to the point where we keep increasing the stress over a period of time, if the stress stays high and the time goes on, we get to the point of failure. That's injury. Okay? You got a question?
Nope.
Oh, okay.
Just stretching.
Yep. So the notes down here. Tissue undergoes levels of strain as the stress load is increased. Strain is the amount of deformation that occurs when the load is applied. That's here. Region of the stress strain curve are as follows. The toe region, it's just the initial part of the stress. Elastic limit, it can come back from this. Plastic range, when it's in this range, we are lengthening permanently. Permanently lengthening here. This is usually what we're trying to achieve if we're stretching. But if we get to this point, we've got tissue damage. Does that make sense? Now, what happens if we apply heat to this? It increases, right? We get more of all of this. And hopefully we head this off a little bit further down the line. Okay? So when I say add heat, what do I mean?
Increase blood flow.
What kind of heat can we apply?
Like a hot plate.
Hot pack. Does it get deep enough? Maybe, maybe not. What else?
Ultrasound.
Ultrasound. Does that get deep enough?
Yeah.
Maybe, but very limited space, right? Very limited. What's the best way to heat something? Exercise it. Okay? That's what warm up does. That's why you're able to stretch better after warming up. That's why we're studying this. Types of stress, these are things that you're going to hear terms. Tension, force parallel to the cross-section area. The tissue stretching is a tensile force. Compression, just the opposite. Shearing force, that's going to be parallel to the cross-section area. That moves this way. Strains the amount of deformation lengthening that occurs when stress is applied, as we talked about earlier there. Again, here's our definitions of all that graph. Effect of mobilization, inactivity, age, corticosteroids. What in the world? What do corticosteroids do?
They relieve inflammation.
They do. They can be very effective, but they can also have a very destructive effect to joints and so forth. Have you heard of people that have multiple cortisone shots and all of a sudden something happens and their joint fails basically?
Is it because of the pain relief? They overuse it?
No, it's physiological. The corticosteroid breaks down parts of the joint and it takes away a lot of the bad stuff, the inflammation and everything, but it also takes away some good stuff too. So if you get too many of these cortisone injections and so forth, you really put your joints at risk. Not just joints, could be whatever's in the joint too. Like if you do it in the subacromial space, if you've got inflammation there, hey, maybe it shoulder feels great, then you can move it again. But if you keep doing that and doing that, your cuff gets worn down, that articular cartilage gets worn down, it leads to problems. So you don't need too many of those things. Types of stretching, here we go, Miles. We've got static, cyclic, ballistic, P&F, manual, mechanical, self-stretch, active and passive. Again, just like we talked about on Friday, all of these things can determine what our stretch is going to look like. The alignment, our stabilization, the intensity, the duration, the speed, the frequency, and the mode. All of those can affect it. Let's talk about each one of those. The alignment. We've got to be aligned properly to stretch more specifically, okay? Am I going to stretch the bicep fully if, it's hard to really say. If I'm in full pronation and I try to stretch that, is that going to be the best way to do it? No. That's already putting it in stretch, right? So we might want to be in a more neutral position to get that full effect. That's the best example I could come up with that. I'm sorry. Hamstrings and rectus, it tells me. So, if we're looking at hamstrings, I don't know if I showed you all this yet. Everybody get up. It's gonna be hard. I don't have enough space. I need one person. Sit right up here. John, stand and see this. We're gonna bring this leg over here. And this one straighten out. Back up. There we go. All right. So if we're here, and we have Maggie to stretch her hamstrings, we have her which hamstring do you feel it more? More medially, right? okay? Look if she turns this way. And then like that. Where do you feel more outside there? So alignment's gonna be really important on how we stretch a certain muscle, okay, or muscle group, if you will. Thank you. Stabilization. I always say to you guys, you do a manual muscle test, the order gives you 2 hands, use them both, right? Same thing when we're doing passive stretching. Make sure you stabilize a proximal segment, okay? Intensity. Low load stretch more comfortable to the patient, therefore probably better for the patient. Low load's going to minimize the guarding. If we couple that with a long duration stretch, you're going to make the most impact there. Duration. How long? Lots of controversy here. Okay. Do we like two reps of 30 seconds or 6 reps of 10 seconds? Because both add up to 60 seconds of stretch. Okay. I tend to say longer than shorter. But what are patients going to do? They're going to do shorter. That's why we got to sit there and count for them a lot of times. Yes, sir.
Why?
Why?
Why longer?
Why longer? Longer because, again, if we go back, because the intensity is probably going to be a little bit less, more comfortable, as opposed to if I push a stretch, they're only going to be able to hold it so long. The likelihood of that making more changes and not injuring somebody is less. I think we got more of a problem there. That's why I would tend to go with more of the 2 times 20 seconds. You know, I'll tell, you know, have somebody in the clinic and I want to stretch their gastroc. I'll have them hold it, you know, 20 seconds and do it 5 reps. But there'll be another therapist in the same place that's going to have them hold it 10 times for 10 seconds. I don't know that one is more right than the other. It's just kind of what I've gotten used to doing. I do know this though. If you ask your patient to hold it for 10 seconds, they're going to hold it for 5. Therefore, I at least, if I can get 20 out of them, I'm at least getting something there. Because I know if they stretch for 5 seconds, that's really not going to do a whole lot of good. Static or sustained force just past the point of resistance. Again, that's that static versus a cyclic stretch where you hold, then you repeat that. Again, shorter duration. It's got some proposed benefits. There's a lot of controversy with these things. Speed of stretch. Slowly applied stretch provides less tensile force, less neuromuscular activation, therefore safer. Ballistic stretching, rapid, forceful, intermittent. Equal improvement according to studies, but again, I think we run the risk of injuring folks more with ballistic than we do with static. Certainly not recommended for elderly, sedentary, or those with musculoskeletal pathology due to that greater trauma to these stretch tissues. These are the people that are at risk. We can't afford to do the ballistic stuff with them. But again, we're dealing with elite athletes. We're talking about, we don't want to slow somebody down that's getting ready to go run the 100-meter dash for the gold medal. Because the studies do say static stretching is going to slow things down. Your firing patterns are not going to be as quick. So that's why you'll see them do more ballistic stuff. It's really interesting to think about all these things. There's all kinds of studies that have been done. And probably none of them are terribly conclusive. Frequency, how often should we do it? Nobody really knows. We guess that 2 to 5 sessions a week is good. Well, that's pretty broad anyway, 2 to 5. Why not daily? Why not once a week? I think this is very individualistic as well. My roommate in college, when we played baseball, was a little guy, 5'8", 165, solid as a rock. I mean, just totally built, no fat on him at all. Stayed hurt all the time and loved to stretch. He just stretched and stretched and stretched, but he would pull a hamstring getting out of bed. And I don't know that all the stretching that he did was good for him. We were totally two different body types. I was no muscles, but very flexible. And he was just the opposite. And I never got hurt, and he stayed hurt. So I'm just kind of going about what I go from personal experience there. Some people need more stretching than others. I certainly need more strengthening than he did. And what do people want to do? They want to do what they're good at, right? Strong people want to go to the gym, and flexible people want to stretch for the most part. So I think it's our job to reverse that trend. If someone is very, very strong, more times than not, they need to work on their flexibility. This is just a sidebar, no slide on that one. Mode of stretch, lots of different ways we can stretch. There's no best type. You got to consider what the person has at hand. Are they going to have a personal trainer that can do this for them all the time? Great, if they do. Not many people do. Do they have a gym? Do they have a location that they can do this frequently? Do they have comorbidities? What stage are they in the healing process after their procedure or after an injury? The duration of their hypomobility. So if I've got Mr. Spades, who's been tight for 21 years now, am I going to be able to get him flexible in a week or two? No. But we're working on it. Slowly but surely. And then the capability of the patient and the caregiver. You know, everybody's got a different circumstance. What are they going to be able to do? What's realistic? Modes. All right, this manual stretch, which is great. Love manual stretch. Therapist controls the speed, that stabilization, the alignment, all those things. Certainly appropriate in early stages to see how the patient responds. We can give them cues. We can do lots of things. We can control this, which should be a good thing. But the cons, it's debatable on the effectiveness versus anything else. Probably due to those short durations. Hold it longer. Self-stretch, certainly it's cost effective. Enables to maintain results achieved by the therapist. This might be after discharge. Certainly useful in long-term and chronic situations. Cons, if they do it wrong, it might be worse for them. Stabilization can be really hard. Safety concerns, if somebody's going to stretch to the point that they hurt. Lots of different things to consider there. Mechanical stretch. Has anybody seen, there's a really prominent in golf now, is a thing where you sit down in, put your legs in, so you're in this position, and there's a bar that goes up that can go this way and down and forward. It's a stretching machine, if you will. It's amazing. Let's see if I can find a picture of it. That's it. Look at that. $3,300 for a bunch of metal. But boy, oh boy, can you do all kinds of different stretches on this. This one's also pretty good. we had one of these. And we had. Looked like this, except it was more dynamic. Legs went out on this one. Again, if you've got somebody that's doing this for a living, it might not be too much for them to pay $3,300 to have something that really is effective for them. But that's not many people. You know, again, when you think about mechanical stretch, some devices will allow patient control, some are preset. That makes things hard because they don't know how far to crank something, whatever. Permanent gains are not maintained if you don't increase the range of motion, so that's going to become more therapist dependent. Certainly the cost. Can they wear it correctly? Can they apply it? Serial casting. Everybody know what serial casting is? You got somebody with elbow flexion contracture. You get them about 10 degrees more extension, you put them in a cast. You let things stretch out for a week. Then you come back and you stretch them 10 degrees more, you cast them again. That's serial casting. Okay, yes?
I have an Aquinas brace.
Do you really?
Mm-hmm.
Can you bring it?
Mm-hmm.
All right, I'd like to see that. That'd be interesting. But you got, that can be messy, costly, and you've got issues with skin breakdown on those things as well. PNF, proprioceptive neuromuscular facilitation. So we had a class, an entire class in PT school about PNF. We had a great instructor for it. We're gonna have it in about 10 minutes here. So again, this is a facilitation technique that will try to inhibit what you don't want to be firing. If you've got somebody with muscle spasm, this is a great way to try to limit that. Historically thought to be more effective due to the autogenic reciprocal inhibition that we were talking about, but current thinking that is more complex. Of course it's more complex, it's never that easy. But the techniques are hold or contract, relax, agonist contraction, hold, relax with agonist contraction. We'll go over these in the lab for sure. Agonist is the muscle opposing the one being stretched. They're gonna do a concentric contraction to move the limb to whatever means you want to try to stretch the antagonistic muscle. Okay. Again, we'll go over these in lab. Special considerations. Anytime you see these boxes in your text, they're pretty good to know. They do a good job of summarizing things. Special considerations for mechanical. Precautions for stretching. Okay, just general precautions. Do not force a joint beyond normal range of motion. Is that just understood? It should be, but you know, some people just want to keep pushing and pushing. Valsalva. Do we want people to hold their breath the whole time when they're stressing, they're bearing down and all that kind of stuff? No. Breathe, people, breathe. Tissue status, obviously we've got fractures to consider, age, chronicity, wounds that are healing. If you've got somebody with a swollen joint, it's not gonna be easily stretched, not gonna be comfortable for them. So you gotta progress these very gradually, if at all. Might not be a time to stretch. You see there's a lot of it depends in all this, right? Adjuncts to stretching interventions, we already talked a little bit about this. So relaxation training. This might be something, you're not gonna learn a whole lot of that in here, but this might be something that you learn from another clinician or a continuing ed course or something like that. You can pass that stuff along to patients. It can be incredibly effective. Yoga training, things like that. Heat, we already talked about. Whether it's an actual exercise, moist heat, ultrasound, whatever. Cold before or after. Is that gonna help with the stretch?
No.
Probably not. It's probably gonna reduce the amount of stretch that can take place, but what can it do? Reduce the pain. So you might have somebody that wants to go get in an ice bath before they do this kind of stuff. Plenty of athletes do that. Massage. Seen the benefits of that already, right? Certainly be a good adjunct to what we're doing here. Biofeedback. We do not have a biofeedback unit here because insurance has kind of just said they're not going to pay for this. But what does that mean? So if I've got a muscle and I've got electrodes set up to this muscle, biofeedback will register, whether it's a beeping sound or a light that flashes or whatever, when there's muscle activity there. Okay? So if I've got muscle activity, is that the time to stretch? No, we want it to relax. So if you can get the muscle to relax through this biofeedback, then you know now it's a better time to stretch. Biofeedback can work the other way too. If we've got a quad that's inhibited, somebody's had surgery, they've got swelling, they've got nerve damage, whatever the case may be, and we can't get that quad to elicit a proper contraction, that biofeedback can give them feedback immediately that says, okay, nothing's happening over here, we gotta get some more. And somehow, some way they go through this neural pattern and they get some contraction there and that machine lights up. It's amazing to watch someone say, oh, now I figured it out. I gotta do this to contract that muscle, or I've gotta have it in this position, or I've gotta externally rotate my hip, or I've gotta have it a little bit of flexion. And it just jumps up. Yep.
Would you use this for neurological patients?
You can. You can. I think you'll probably see it more in that setting than you will in any, to be honest. If you see it at all. Because again, insurance has pretty much said, we're not covering that. We've talked a lot about joint distraction, oscillation. All those things can really help prior to stretch. Okay. All right, prepping for lab. Let's take a break. Be back at 11. Let me get through this peripheral joint stuff.